Hi, Dr. Girija. Um, Good afternoon. Am I audible and visible?
Yes, you are.
Perfect. Great. We'll
Yes, you are.
wait for 2-3 minutes before I start.
Sure.
Okay. Okay. I guess, Dr. Girija, we should start. Yes. So I think a lot of people have joined us already. People are joining us, in process of joining us at least. So, yes. So, a very good afternoon, everybody. A very warm welcome to today's webinar. I'm Dr. Astha Gaur. I lead marketing strategy at Janitri, and it is my absolute pleasure to be your moderator for today's session. On behalf of Janitri, I'd like to sincerely thank every one of you for taking the time to join us. We truly, truly appreciate your presence and commitment to continuously advance maternal and neonatal monitoring. In theme of today's webinar, that is intrapartum surveillance, the science, the signals, and the science, an exploration of how science and clinical judgment come together during one of the most critical phases of childbirth. Labor is one of the most critical phases in maternity care, where every decision is guided by timely clinical observations and accurate interpretations. Understanding the science behind the signals enables clinicians to intervene at the right time and with greater confidence. To guide us through this important subject, we are honored to have Dr. Girija Wagh, okay, a highly respected obstetrician and gynecologist with over 34 years of clinical, academic, and research experience. Dr. Wagh has had several distinguished national leadership positions, including former Vice President of FOXI, National Mentor for Government of India's Lakshya Quality Improvement Program, playing a key role in strengthening the quality of maternal and newborn care across India. She is widely recognized for her expertise in high risk obstetrics and has delivered more than 2,500 scientific lectures, inspiring clinicians across India. Dr. Wagh, thank you so much for taking the time to be with us today. We look forward to learning from your vast experience. Over to you, Dr. Wagh.
Thank you, Dr. Asta, for giving me this wonderful opportunity. And yes,
You
with all the new things that are happening in our lives, it's become extremely important that we understand how best we can lead the birthing experiences for women all across our country.
absolutely.
At the outset, I would like to really appreciate the contributions done by Janitri Innovations in helping us doctors and obstetricians and healthcare providers, especially the delivery assistants, to ensure that women have a safe birthing experience and the babies are protected. So thank you so much for having this session. And I'm sure and I hope that I'm able to reach to your expectations and I'm able to deliver what is essential.
We have no doubt. We have no doubt.
Thank you so much. So, we have decided to call this particular session as Fetal Monitoring in Labor, an evidence based interpretation and clinical actions. And it has been updated to the recent evidences, whatever are available in the literature and through our experiences. Thank you, Asta, for giving me that wonderful introduction and setting the stage so that I can take this forwards. We all are aware that having knowledge of education is a good thing, but it properly is the most important thing when you use it. And that's what Himcom says. So having knowledge of education is a good thing, but using it properly is the most important thing that we have to be aware of. Now, today we are going to be looking at the physiological basis of FHR changes during labor, describe the evidence-based methods of fetal monitoring, interpret CTG using updated frameworks such as the NICE, FIGO, and the physiological issues, identifying types of hypoxia and correlate with CTG patterns, and apply structured action plans for abnormal CTG. Now, why fetal critical?
Yes. I think Dr. Girija, there's a lag from your side in terms of audio and video. Yeah, it's all good. Please continue.
Is a leading cause of stillbirths up to 30% globally, neonatal encephalopathy, long-term neurodevelopmental impairment, and timely detection of fetal compromise can prevent such adverse outcomes, reduce unnecessary C-sections, and improve neonatal and maternal satisfaction. The global perspective today is the WHO 2023 Labor Care Guideline has now started replacing the traditional partograph. It focuses more on individualized, respectful, evidence-based care and encourages intermittent auscultation in low-risk women. While the FIGO and the NICE guidelines emphasize on physiological interpretation over rigid categorization and advocate for structured response protocols. So there are certain physiological mechanisms which maintain oxygenation, and we have to look how do they do that. If you look at the oxygen pathway, it starts from the maternal lungs. When the mother breathes, it will deliver oxygen to the placenta and the fetus. And the fetal will adapt depending on various things through its own cardiac output. There's a blood flow distribution throughout the fetus's body, and anaerobic metabolism and its metabolites are released back to the maternal circulation to be released out. During labor, there is going to be uterine contractions, and we all know that uterine contractions give rise to some squeezing of the uterus, wherein there can be a certain compromise in the uteroplacental flow, but this is quite well dealt with by healthy fetuses, and whether if there are going to be any compromises can be beautifully identified by proper fetal surveillance during labor. Now let's see how uterine contractions affect the uteroplacental blood flow. So we all know that from the mother, the uterine contractions and relaxations, they will affect not only the mother, the uterus, but also the fetus. When there is a blood flow replenishment, reduced uterine pressure, reduced maternal stress, there'll be increased fetal oxygenation. While when the uterine pressure increases, there's going to be maternal pain, and that's also going to cause a lot of breath holding, and the fetal blood flow would reduce at that time. Now, especially so will be seen in the context of synthetic oxytocin, which we are using externally, because these contractions are stronger and frequent, and therefore they will award a very less relaxation time and a less opportunity for replenishment. And therefore, it is essential that whenever you are using a synthetic oxytocin, the patient is closely monitored. Whenever you're using it for augmentation, we have to remember that we have to closely monitor these patients. Why? Because the continuous infusion will give rise to strong, frequent contractions. There'll be no central effects such as no endorphin-mediated pain relief or emotional modulation, which happens with oxytocin. We all know. Just excuse me for a moment. Sorry for that. We all know that oxytocin is a hormone of love. And Naturally, it is released in a pulsatile manner. Rhythmic, gradual contractions are the result. It crosses the blood-brain barrier, causes endorphin release, and emotional calm. And therefore, in a physiological labor, there's adequate recovery between surges, which maintains fetal oxygenation.
Do you need a minute, Dr. Girish?
No, it's fine. But there is risk of hyperstimulation, which will be seen typically in synthetic oxytocin, where because of compromised uteroplacental perfusion, there'll be possibility of increased fetal distress. So what are the clinical monitoring guidelines when you're using external oxytocin? Begin with a minimal dose, titrate based on contraction pattern and fetal response. Always use a continuous CTG monitoring, assess baseline fetal heart rate, variability, accelerations, and results. Watch for hyperstimulation. What do you mean by hyperstimulation? When there are more than 5 contractions in 10 minutes or less than 60 seconds. Relaxation, reduce or stop infusion. Monitor vitals, pain, uterine tone, and fluid balance correctly. Discontinue oxytocin if signs of fetal compromise or uterine tachysystole occurs. And achieve effective labor while preserving fetal oxygenation and maternal safety. Now, there are major changes in the WHO 2023 LCG, which introduced compared to the traditional partogram. And there has been a focus shift now from labor progress monitoring to woman-centered evidence-based care. It abandons the 1 centimeter per hour cervical dilatation rate rule and recognizes variabilities of labor progression. It stresses more on individualized assessment, and it therefore takes care of rigid action lines. Sorry for this. Okay, so we start again. I'm sorry. It also stresses more on clinical judgment and individualized assessment. It includes maternal well-being, fetal status, supportive care interventions. First and the second stage of labor are now documented in the labor care guide, which were not done in the previous partogram. And now we also have digital and paper versions of electronic health records and low resource settings. And of course, there's a huge emphasis on shared decision-making and respectful maternal care. Now, the NICE 2022 and the FIGO 2024 guidelines, they do differ a little in the CTG interpretation, and we'll see how. Now, if you look at the NICE 22 updates, there's an hourly risk assessment, simplified CTG categorization such as normal, suspicious, pathological, instead of reassuring, non-reassuring, and abnormal. Emphasis is on how is the baby approach. In FIGO 2024, external monitoring is first, internal if the trace is poor, continuous CTG for high risk or abnormal intermittent auscultation, avoid routine admission CTG in low risk women, and there is a stress on physiological interpretation as per the 2024 consensus, which has moved away from arbitrary grouping, and it speaks more of fetal compensatory versus decompensatory patterns. The zigzag pattern, the autonomic instability, and the chorioamnionitis features have received a lot of attention there. So let's look at the physiological interpretation of CTG. One, the baseline heart rate, about 110 to 160. Baseline variability, normal 5 to 25 beats per minute, reduced is concerning. Accelerations are always reassuring. Decelerations are bothersome. Early ones would be benign or maybe physiological. Variable may be because of cord compression, and sometimes with positional variation may change. While late are concerning because they will depict uteroplacental insufficiency. and sinusoidal, where there is severe fetal anemia or hypoxia, which would be of concern, especially in babies of an abruption placenta or RH incompatibility if they are delivering. So when should intermittent auscultation be preferred over continuous CTG is an oft asked question. Now, this is a normal CTG, as you can see here, fetal heart rate. These are the movements which are perceived by the mother, which are marked here. Then fetal movements will be recorded here by the machine, and uterine contractions are also taken by the TOCO probe, which is attached to the mother. So you can see the TOCO probe and the heart probe. So the questions which often come to our mind is, should all patients in labor be monitored by electronic fetal monitoring? How do we decide this? Whether there has to be an admission assessment, and are there any risk factors? And I told you the consensus that there is no need for doing admission assessment for who are low risk women. So methods of monitoring are intermittent auscultation for low risk women every 15 to 30 minutes. First stage, every 5 minutes it will be in the second stage. In fact, our old time teaching has been that it has to be done after every uterine contraction, and that is always wiser. Continuous CTG, of course, in women who have either abnormal intermittent auscultation findings or in women who are high risk women. And of course, one can consider using things such as fetal scalp stimulation, fetal scalp blood pH and lactate and STAN. Of course, these are not very easily accessible and available. And I have zero experience of using them because I never found them essential. We have to ourselves decide as to what is going to be the best way for our patients to monitor. And these are how things are taken. So you can see here a scalp electrode being attached here, which has been identified to be quite interventional and not really essential always. But we must know about these informations because now the technology is advancing, and you never know that we'll come up with much more non-interventional advanced ways in which we can look at these babies, and therefore we must be well aware of the knowledge. So what is STAN? Let's find out, and how does it help us in improving detection of hypoxia? So basically, it combines the fetal ECG with CTG to detect fetal hypoxia during labor. As you can see here, the STAN, which is applied here with various amplifiers, it's looking not only at the CTG, which directed vibrationary actions of the fetal heart movement through the live cord to the mother's, to the uterus surface where we capture it, but it is also taking the probe of the ECG recording of the baby, especially the ST segment, which reflects fetal response to stress. Scalp electrodes will be necessary, and therefore it will become interventional and membranes will have to be ruptured. And usually, advantage is it will give us automated alerts, which are abnormal patterns. And clinical judgment, of course, would have to be essential to identify and learn how to interpret these things. What are these indications of fetal blood sampling? Because some of us do have an access to doing this, and we should be aware when to do it. Whenever there is bradycardia, complicated tachycardia, recurrent decels, prolonged brady, or atypical undefined decelerations, persistent loss of variability not corrected by fetal stimulation, and non-specific concerns regarding fetal well-being, we may consider doing fetal blood sampling, especially when the CTG is pathological. The contraindications would be when there is clear CTG evidence of severe sustained fetal compromise requiring urgent delivery, maternal infections such as hepatitis, HIV, HCV, which would cause intrauterine sepsis, suspected fetal bleeding disorders, face, bro, or breech naturally, and gestational age less than 34 plus 6 weeks of duration. Now, how do you interpret them? You get the lactate levels, and if they are less than 4.1 per liter or pH is more than or equal to 7.25, it is taken as normal and you can continue the labor with a close CTG monitoring. If the lactate levels are 4.1 to 4.7, then it's taken as borderline, and you can consider repeating the FPS within 30 minutes and inform a senior obstetrician, of course, and reassess mode of birth if values are deteriorating. Lactate more than 4.7 is taken as abnormal, and here birth is indicated, and lactate more than or equal to 5.8 is severe acidemia, and immediate delivery would be necessary, and maybe we may have to consider taking her for a cesarean section. So let's look at the various variabilities that are seen on CTG and the clinical implications and interpretations that we do. As we discussed, fetal heart rate 110/60 is the range, variability, and fluctuations in the FHR amplitudes actually are welcome because they tell us about the CNS and adequate oxygenation. Accelerations tell us that the fetus autonomic and the parasympathetic system is normal and it is responding to kinds of activities of the baby. Decelerations, if they are early, would be benign, late would be an implication of hypoxia, and therefore we have to correctly interpret and understand them. Now, variability, as I said, is always welcome because it's a best indicator of fetal oxygenation and neurological integrity. And loss of this variability would often precede a fetal compromise. And tachycardia is another implication that we have to be aware of. And especially now, CTG is of great importance because there are many women who are now presenting to their second births with the first previous section. And especially in a woman of previous section, when you're giving her TOLAC, that is trial of labor after C-section, your continuous fetal monitoring and interpretation of the fetal well-being is extremely important because there are certain signs which tell us that there is going to be a change in the intrauterine pressure, maybe because of dehiscence, which can affect the fetal well-being. Now let's look at Mrs. A, who is a 28-year-old primary gravida at 39 weeks. She is in spontaneous labor. There are no comorbidities, and it's a completely low-risk pregnancy. Initial intermittent auscultation was normal, and she was progressing well in active phase, and suddenly she started complaining of dizziness. The CTG was initiated, and it showed a baseline heart rate of 170 beats per minute, reduced variability, and late decelerations. So what does this tell us? That there is some jeopardy and there is tachycardia. Now, patient had gone into active phase of labor. There is tachycardia and there is reduced variability and late decelerations. Now, this is something which is definitely concerning. So you can see that here you can appreciate that this is the range of the normal fetal heart rate and this is the tachycardia on the CTG graph. And here the fetal movements are being marked and this is the uterine contractions. And if the baseline fetal heart rate is more than 160 beats per minute for more than 10 minutes, normal baseline into 160, it is defined as tachycardia. Now, why is there tachycardia? It can be maternal factors such as fever, dehydration, chorioamnionitis, hypothyroidism, or medications such as beta agonist or atropine. Fetal factors such as hypoxia, early sign of stress, fetal infection, anemia, and labor interventions such as hyperstimulation due to oxytocin and epidural due to maternal hypotension giving rise to compensatory tachycardia. Now, tachycardia alone is not pathological, but when combined with reduced variability, late decelerations, as we had in Mrs. A, it suggests evolving fetal hypoxia and an urgent action is necessary. So, the physiological mechanisms of tachycardia are increase in the sympathetic activation because of stressors. Catecholamines such as epinephrine and norepinephrine undergo a surge and they are released in response to stress and direct myocardial stimulation they will cause. And reduced parasympathetic maturity, especially in preterm fetuses which are underdeveloped, vagal tone, there can be reduced heart rate modulation and this has to be remembered. So whenever you are monitoring the electronic fetal monitoring in a preterm baby, you have to be a little careful when the patient is in labor because the peak of more than or equal to 15 beats per minute above the baseline and duration of more than 15 seconds but less than 2 minutes from onset of the acceleration to return to baseline is something that we'll typically see in term fetuses. While before 32 weeks of gestation, the peak will never be more than or equal to 10 beats per minute above the baseline of a duration of more than 10 seconds. So be careful when you're interpreting patients who are taking some chronic antihypertensive medicines, are in preterm birth, and then your interpretations would not go wrong because we should not land up in doing unnecessary interventions when they are not needed. So when we are talking of electronic fetal monitoring, we have to look at the correct correlationships whenever there are abnormalities, such as loss of variability, infection, decelerations can be due to occult cord compression. Gestational age should be considered, and a non-reactive test followed an earlier reactive result is highly suspicious. Now you can see here that normally when we look at tachycardia, it is not a sign of hypoxia, but maybe early feature of hypoxia when the fetus is trying to compensate. So you can see that the cardiac heart rate has gone up, but you're also seeing that the variability is not very happy. And therefore, we have to look at this because this is completely not only more than 180, but it is also an abnormal trace. Tachycardia with normal baseline variability and lack of deceleration does not suggest any fetal compromise. But associated decrease in variability and decelerations should always alert us. And you can see that there are uterine contractions happy, and then it is a little concerning, and you have to interpret in accordance. Of course, you have to also the maternal pulse and try and identify because there can be a correlationship. Usually, maternal pulse and bradycardia can be, as well as tachycardia, can reflect similarly. Now, whenever there is bradycardia, it means is increase in the vagal tone or a sign of myocardial depression, which is terminal to fetal death, if associated with decreased variability and functions. It's always due to fetal hypoxia. Cardiac arrhythmia, complete heart block also can sometimes be present, but usually you may have noticed that before the woman went into labor. And always when you see antenatal, it's always a good practice to notify your notes that you are aware that she has a bradycardia. Now, variability typically is very important because it would refer to the beat-to-beat fluctuations in the fetal heart rate. It is an interplay between the fetal nervous system, chemoreceptors, baroreceptor responsiveness, and it is a key indicator of fetal well. And a healthy fetus continuously keeps on adjusting its heart rate to the surroundings. Normal range has to be between 10 to 20 where from deviating from the baseline, and it will help us evaluating the extent to which the peaks and the troughs of the fetal heart rate deviate from the baseline rate. You can see here this is minimal, that is less than 6 to 25 beats per minute, and this is more than 25 per minute. So you must be able to look at the variability and interpret. Now, less than 5 beats per minute variability for more than in the absence of decelerations or more than 30 minutes, decelerations is taken as reduced variability. Reduction. It is because of the autonomic imbalance where the sympathetic and the parasympathetic nerve undergoes depression, and this is because of hypoxia or acidosis. Of course, one must remember that there are fetal sleep cycles where there can be temporary reductions in variability which may occur during normal sleep states and last less than 40 minutes. Some medications such as opiates, magnesium sulfate, corticosteroids, or maternal sedation can suppress fetal activity and reduce variability. And sustained reduction is a non-specific but concerning sign of fetal compromise, and it may reflect decompensatory physiology where the fetus is unable to adapt to the stress. Now let's look at decelerations. They refer to a transient drop in fetal heart rate below the baseline, typically lasting for more than 15 seconds and more than 15 beats per minute in amplitude. And they may indicate fetal response to stress, especially hypoxia or cord compression. And onset in relation to contractions has to be seen. Depth in the duration and the recovery pattern will help us in identifying these issues. So there are various types of decelerations, such as early, variable, late, prolonged, and sinusoidal. And especially the early ones would be because of head compression, variable due to cord compression, late uteroplacental insufficiency, prolonged due to hypoxia, cord prolapse, prolapse, hypotension, and sinusoidal can be ominous, telling us that there is acute fetal anemia or hypoxia. And it is again because of vagal stimulation, umbilical cord compression, and reduced uteroplacental perfusion, as we have understood. So whenever we are looking at the CTG, which is showing tachycardia, reduced variability, late decels, initial assessment consists of maternal vitals, position, contraction pattern. Conservative measures such as left lateral position, IV a little propped up, IV fluids, stopping oxytocin, tocolysis if needed. Reassess CTG and look for improvement, and otherwise escalate for a senior review. And maybe you may consider the additional things which usually we do not, but we look at the patient's progress during labor and then take a call whether we are going to expedite the delivery by instrumental assistance or cesarean section. Now, antenatal maternal problems have to be looked into when looking at all these decisions, such as previous C-section, preeclampsia, prolonged rupture of membranes, whether this labor is induced, whether mother is diabetic, antepartum hemorrhage, and other maternal medical disease. Other fetal problems are fetal growth restriction, prematurity, oligohydramnios, subnormal Dopplers, multiple pregnancy, meconium stained liquor, and breech presentations, and intrapartum risk factors such as augmentation, epidural, vaginal bleeding in labor, fresh meconium staining, and maternal pyrexia. One has to remember the various depicted sequence, which is an approximation, and the actual course may vary depending upon the characteristics. So it starts with stress, where there is chronic respiratory and nutritive insufficiency. Then there are primary adaptive responses by the fetal growth. And then there are secondary adaptive responses which can happen, which we have to be aware of. And these will give rise to progressive decompensation during labor. And if we are not on guard, may go into death. So you can see here in this picture the prolonged decelerations, and this is typically seen following a vaginal examination. You can see a prolonged deceleration following a uterine rupture, and this is something which you have to be very careful. And you can also appreciate another prolonged deceleration here. So we have to look for what are the possible reasons why this is happening. And you can see what can happen during uterine contractions here. You can see that the uterus contracts. When the uterus contracts, it squeezes the placenta. And sometimes it may cause placental detachment, retroplacental hemorrhage. And you can see in this picture here, there's a sinusoidal pattern, which is telling us that there is abruption and placental separation, which has given rise to these very, very acute and prolonged hemorrhage. Likewise, here you can appreciate this can be because of not only placental separation, but some sort of an acidotic insult of the baby, which requires immediate action. So placental insufficiency and umbilical cord occlusion will give rise to fetal cellular hypoxia. And there have to be a watch out for fetal problems such as erythroblastosis, hemoglobinopathy, which can be present priori or it can be induced by fetal growth restriction or macrosomia. Maternal problems such as hypotension, hemorrhage, hypoxemia, and infection. It may be acute or prolonged. If it is acute, such as tachycardia, reduced variability, late decelerations or accelerations, it may cause cell enzyme dysfunction. If it's prolonged, then there is metabolic acidosis may or may not be present. Bradycardia, reduced variability, late decelerations, absent accelerations signify cell death, and this has to be remembered. So whenever we are looking at these various components of fetal surveillance, we have the non-stress test, where we call as reactive, non-reactive, and it would give us a false positive rate of assurance of 55 to 90%, false negative 0.2 to 0.65%. And the stillbirth rate within 1 week of a normal test result is about 1.9 into 1,000. When you're doing the biophysical profile driven by sonography alongside a reactive NST, and you say that it's normal more than 8 on 10 or 8 on 8 excluding NST, equivocal 6 on 10 and abnormal less than 4 by 10, false negativity is 0.07 to 0.8%, 40 to 50% false positive, and stillbirth rate of 0.8 per 1,000. So you can see that the biophysical profile stands out better than the non-stress test, but we have to use them in conjunction, especially when we are looking at who are sick or the mothers who are sick, and modified biophysical profile, where you're using both in conjunction the NST as well as the amniotic fluid index. These would help us in giving us an identification of 0.8 per thousand. And therefore, currently, much of our surveillance has moved towards non-stress test and the amniotic fluid index, where the maximum vertical AF pocket is more than 2 centimeters, and that helps us in better dealing with these things. Now let's look at another patient, Mrs. JT. She is 33, primi gravida with severe acidity, anemia, which was corrected from 7.2 grams per deciliter to 10.5 deciliters. And you can see that she has come for an admission test here, where you can see because she was anemic, we decided to do this admission test. And you can see that it was showing a good reactive NST, good accelerations, good variability, good fetal movements, and a uterus which is just about trying to kick up. Then you are also seeing another patient here who is showing tachycardia, but then there are good variabilities, as you can see here, movements, and the uterine contraction has just started. This was a patient of GDM controlled on MNT diet and a hypothyroid woman. So we had done her admission CTG. Now you can see Mrs. MR, who is 36-year-old, hypothyroid, obese, class 1, gravida 2, para 0A1, and 19 weeks GDM MNT diet. 28 weeks we started her on metformin and till term, and she is doing CGM monitoring. 32 weeks gestational hypertension, started on labetalol 100 milligram BID. Her urine protein creatinine ratio has come normal, and she said that she has decrease in the fetal movements. She had ICP, that is cholestasis of pregnancy, at 28 weeks, and which was controlled by also deoxycholic acid and with bile acid surveillance. And this is her test, which she had done with a good fetal monitoring, as you can see, with good fetal movements. Now, this patient was absolutely insistent on a vaginal natural onset birth. And therefore, this continuous surveillance was going on, where she took the responsibility of ensuring that her blood pressures will be kept quiet. She'll take care of hers, whatever she can. And that's how we continued despite all these kind of risk factors. And lo and behold, she did have her dream coming true. And this was only possible because of a close surveillance, the CTG and the NST. And you can see that she has delivered vaginally, and immediately the baby has been put onto her breast for immediate breastfeeding. So these things can be a possibility. Of course, the patient has to be there for a decision making, and she also has to be participating actively in her own care. Now you can see here, this is Mrs. S, 34 years, gravida 2, para 1 for C-section with oligohydramnios. 36 weeks plus 6 days regular checkup. We did her NST. And you can see here she has a good variability, no acceleration, but then these also are not taken as decelerations, and a good fetal movement is seen. So this NST was taken, and she was complaining of lack of fetal movements. So what next do you do? So we asked her to go for a walk, take food, water, proper nourishment. And then you can see that her CTG has come back, her uterine contractions have increased a little. There are accelerations, the variability is a little poor here, but then it seems to have improved over a period of time, and there are good accelerations. So, of course, she had pain for uterine contractions. We gave her assurance, antenatal steroids, and then we informed her about early warning signs, and we sent her home. And we told her that at 38 weeks, you come back again. That's about 7-8 days. We'll again repeat your sonography. And she had a normal delivery later on. Now, this is another patient, NS, who is a 36 years old, gravida 3, para 0A2, and she has gestational hypertension, GDM, reduced fetal movements plus pain, and you can see that there are accelerations here, but they are sustained accelerations, but you will interpret this as a normal or a reactive NST. Now, there is another patient, primi, 35 weeks plus 1 day. She had COVID plus dengue and PROM for more than 72 hours. And sonography showed and single live intrauterine pregnancy of 33 weeks with 1300 grams with A51 with normal placentation and placenta being normal. And you can see how her CTG is showing bang on decelerations. And you can see that these are variable decelerations, and we took her up for an immediate C-section. So knowing all this is extremely important. Another patient, Amrapali, 39 years old, suffering from insomnia disorders, presented at 30 to 32 weeks and has all kinds of comorbidities with severe hypertension. She was given labetalol, nifedipine rescue, uterine protein creatine ratio 34 millimeters, BP 180 by 100, and this is how her NST is showing, and there's a deceleration here. And we decided to take her up for an elective cesarean section. So BP control was given, and antenatal steroids, DEXA 6 hourly, magnesium sulfate 23 hours, 1 gram per hour for neuroprotection, as well as prevention of preeclampsia. And then RT-PCR, because we did that during the COVID times, and with an NICU counseling, she was taken up for C-section. After the blood pressure got controlled, you can see here, you can see that there was definitely an improvement in her variability and the CTG. Now, another 37 weeks plus 2 days pregnancy with over diabetes, admitted for pain, and she had a safe confinement after DM control, irritable ANC period, diagnosed as over diabetes at 12 weeks. OGCT is 224, fasting 114, and PP 163, absolutely uncontrolled. And she is on insulin and metformin. Sonography, you can see the findings here, and she has a scar thickness of 3.2. And this is how her NST reading is showing on admission. You can see there is no variability, no accelerations, and the baseline fetal heart rate is at 140 beats per minute. Now, she was taken for an emergency C-section in view of a non-reactive NST. And intraoperatively, you can see that this was a completely thinned out scar. Anterior-uterine wall and abdominal wall were very difficult to deliver, and baby was of 2.4 kg, had a weak cry and Apgar of 6 to 9, and was shifted to an ICU. Sometimes you may have these findings with the cord around the neck, as you can see here. So you can see that there can be a cord, and this cord seems to be going even around the baby's body. And therefore, looking at brady and tachycardia and looking at hemodynamic instability of the mother is extremely important. And this is that patient which I showed you in the previous picture, who had a deceleration, and we took her up for a C-section, and she was just about 2 centimeter dilated, 40% effaced, membrane present, and she had good uterine contractions but had a cord, and this would have prevented her from getting engaged. And the baby came out crying, and that helps. Now, do you mean that all cords around the neck do not have a good outcome and they have to be taken for a C-section? Not essentially so. You can see that there are 3 loops of cords around, and the baby has delivered nicely vaginally, and is immediately become mother. So late decelerations are characterized by gradual decrease and return to baseline of the fetal heart rate associated with a uterine contraction. And this is something that we have to correctly interpret and look at. And they are a sign of cord compression. And 90 minutes is the question that you should ask for, because now most of the guidelines say that even if there are variable decelerations, it's not an immediate reason why you would take her for C-section like a late deceleration. And that is because of the complete cord occlusion, which can be reverted back to normal. But if there is a shouldering, so you can see here there is a shouldering in this graph. This shouldering is not a good sign. This tells us that there is acidosis, and you'll have to take an action. But you can see here there is an immediate acceleration and a return to normality, which is telling us that there is a reperfusion of the fetal placenta. Now here again, you can see another patient who had come with decreased fetal movements. An admission test was performed on electronic fetal monitoring, and you can appreciate that there are decelerations which are going down to 120, 140. Baseline fetal heart rate is at 150. And after left lateral position, intranatal oxygen and NST, you can see that there is a much improvement in the CTG recording. So you can just continue this patient. She's already gotten into labor, and they can continue being monitored, and they can be taken for delivery. Another patient here, you can see that she had a poor biophysical score, and her gross body movements were 0 on 2, fetal tone was good, amniotic fluid index was 0 on 2, and you can see that the CTG is showing decelerations. There are a number of 2 decelerations. There is a peaking here. There is no cardio, so it's just an NST testing, and BT variability is 5 to 10. Cesarean section was done uneventfully. Baby by of 2.9 kgs was delivered with Apgar, and then it was found that there was thin meconium tail lifer intraoperatively. Sometimes there can be a cord, and sometimes the baby's head may get so stuck that you may have to use force to deliver this baby. Now let's look at Rupali, who has had a convulsion. She is a severe hypertensive patient at 36 weeks of gestation. And then suddenly, while you're doing an NST, you can see that there is a complete, sinusoidal heart tracing. What is this? This is typically a sign of abruption, and you should look for abruption in this patient. Especially, this may happen after you have done an ARM. Normally, for a severe preeclampsia patient, you would consider doing an ARM, and that would help in identifying this condition. So you have to be able to make the head and the tail of everything that's coming by. And you can see here that this is a patient who had fetal growth restriction, abruption at 32 weeks with RPOC. And look at the swinging decelerations that she's having. Now, there was a huge retroplacental which this patient had, and this was managed with blood transfusions, FFPs, BP was controlled, magnesium sulfate was given as a rescue once again. And then you have to be able to understand that why this is because of the RPOC clot. This is definitely hypoxia acidemia sequence. And here there is reduced variability, probably because of abruption and even magnesium sulfate. Now, many times during convulsion, there is a lot of fear when the CTG is going on that we may consider that we have to take this patient for immediate C-section. But remember that during the convulsion phase, there will be such kind of a deceleration, and this initial tachycardia followed by bradycardia, and there can be a sudden drop of FHR, as you can see here in this particular tracing during the convulsion episode, but that will recover back again, and we must not worry about that. Now let's come to 2 new things which have been introduced in the recent consensus, and these are quicklies and tardies. Now, what are quicklies? Any deceleration that has an abrupt drop from the baseline of more than 30, reaching the nadir within 30 seconds from the onset of the deceleration and demonstrating a quick recovery to the baseline may be termed as a quickly, as you can see here. And these are believed to be due to compression of the umbilical cord and resultant transient hypoxemia, and not due to hypoxia and acidosis. And the intervening baseline and variability should be assessed to determine oxygenation of the central organs. If such quickly decelerations are associated with an increase in baseline fetal heart rate, then it can be because of a catecholamine surge, and changes in the maternal position or hydration or reducing the oxytocin infusion may help in restoring the normal baseline to normal. And the tardies are any decelerations which has a gradual drop from the baseline, then recover slowly to the baseline even after the cessation of uterine contraction. And this is typically called as a tardy. And these are due to an ongoing uteroplacental insufficiency and may be associated with acidosis if they are associated with a reduced baseline variability. So look for baseline variability. And these are often due to structural damage to the placenta, like infarction, thrombosis, or abnormal placentation, and therefore cannot be reversed by changes in the maternal position, administration of fluids, or any of those other things which we'll do when a quickly presents. Now, loss of week-to-week variability in a mom with long-standing oligohydramnios should definitely be concerning. Now, this is a 34 weeks plus 2 days, 2,158 grams. AFI is about 7 millimeters, and CPR is showing a middle cerebral artery PI and umbilical artery PI of less than 1. LSCS was naturally done for the salvage of the baby. This is another inclusion in the new terminologies, and that's the zigzag pattern on a cardiotocography, which shows the pattern of the fetal heart rate with baseline amplitude changes of more than 25 beats per minute, lasting for a minimum of 1 minute, indicates autonomic instability, often a sign of developing fetal hypoxia, and is associated with adverse outcomes like lower Apgar scores, cord blood acidosis, and increased neonatal unit admission. If a ZZP or a zigzag pattern is observed, especially during the second stage of labor, immediate interventions as stopping oxytocin infusion or maternal pushing may be necessary to improvise on fetal oxygenation. So, what is very important for us to understand through this presentation and this session is how do we get more healthy babies and fewer C-sections? Has to be the aim and the objectives. And I hope I have been able to give you the right message to help you interpret these things correctly without being overtly interventional and trying to be as rational as possible and as safe as possible for the babies and the mothers. Thank you, Asta.
Thank you so much, Dr. Girija. That was super, super insightful and engaging session. And
Thank you.
what stood out most for all of us, I mean, I'm sitting with a lot of people right now here, is the way you brought case studies to help us understand it even better and what we can do when it comes to the critical situation in homeschooling care, of course. Also, just one side note, I just got to know from a network of mine that around 100 students from AIMS Delhi are watching this webinar. Any message for them? Any message for them? Yes.
I think I must congratulate all of them for being able to be trained in the AIMS Delhi. And they are very fortunate people. And they are the ones who really create all kinds of guidelines for all of us. And therefore, keep going and try to use all the newer consensus and guidelines as much as possible. And let's work towards, I'm not against C-sections at all because I feel they are for safety of the baby and the mother. But we must focus on giving an excellent outcome to both the babies and the mothers. And I always believe, maybe it's an old school thought, that you as an obstetrician being by the side of the patient is the best monitor. But yes, we must understand, and take help of this electronic fetal monitoring, as it is one of the most wonderful tools. And I must tell you, Asta, that we have been using it for a long, long period of time now. From my training, I have been really lucky to use it throughout my practice in the past 40 years. We have been using it very effectively. And currently, we have a lot of these patients who undergo intrauterine interventions like
Yes.
intrauterine transfusions and things like that. Many times, CTG helps us in taking the right decision because that's so easily accessible, easily available, easily interpretable. And we must
Absolutely.
absolutely make most of this particular, because sometimes it goes down in understanding. People feel that there is an unnecessary intervention which is done with this. No, it's going to help us to take the correct decisions, is what my message would be.
Amazing. Amazing. Thank you so much, ma'am. I totally understand the amount of time that there's a lot of paucity of time when it comes to your end. You're super busy, super occupied. And then still you made 1 hour for us. And we highly, highly appreciate that. Also, like we have a few questions. I'll just read it out loud to you. So one person is asking, Barcelona stage 4 shows ECTG less than 3 millimeter per sec, requiring immediate termination. How do we calculate that in our machines? I think they have not corrected a unit, but I hope you got the gist.
Yeah, yeah. So if you have the
Okay.
Barcelona staging system of ECTG where STV is less than 3 m's, and it said that stage 4, and how do you calculate in our CTG machines, is a very important question.
Yes.
Because what are
Yes.
STVs first? They are measured in milliseconds. They reflect the beat to
Yes.
beat variability, which I was talking of. And they require a
Yes.
computerized CTG software, which we don't have. If you have an access, great. But I think shortly we'll be having it with so much of AI coming from everywhere. We should be able to have such kind of computerized CTG softwares. And then we also have to remember that the human visual
Correct.
interpretation cannot estimate this STV. So the Barcelona protocol uses computerized CTG,
Absolutely.
that is the ECTG, the Davis-Redman analysis, and the numerical STV measurements. So for us, stage 4 deterioration includes severe STV reduction, which is correlates strongly with fetal acidemia and impending decompensation. Therefore, if we are using a conventional CTG, which all of us are doing, we cannot
Yes.
equate visual variability. Use standard CTG interpretation plus Doppler findings that will help you. And Barcelona stage 4 criteria involving STV cannot be applied directly without an ECTG. This is something that we have to remember.
Absolutely. Absolutely. So I think we have a couple more questions, but I think we have paucity of time as well. We are nearing the time of closure. It's 4 p.m. already. So I'll be sharing those questions with you, Dr. Girija.
No
As and
problem.
when you have time, please answer them, and I'll share
Certainly.
that with the relevant people.
Thank you
So
so much.
a very, very thank you to you, Dr. Girija, and from Janitri side, from our side, and from around 200 people who are streaming it right now. It has been such a pleasure to have you. And I reiterate that it has been the paucity of time from your end, but you still took 1 hour from our side. And
It
so
was a
thank you.
pleasure, and all the pleasure is mine. I love to share whatever little I can. And I'm really grateful to you for this wonderful opportunity.
Thank you so much, ma'am. Thank you so much. Means a lot to us. I'll be sharing the questions. And thank you everybody to join us for joining us from, I think we have people from all over the country. And of course, from AIMS Delhi, of course, from a lot of nursing institutes and a lot of hospitals. I think every particular stakeholder has joined this webinar. So it means a lot to us. Your time means a lot to us. And from everybody's side, thanks a lot, Dr. Girija, again for joining us.
Can I request you something,
Thank you
Asta?
so much. Thank you so much, everyone.
Can I request you something,
Yes,
Asta?
absolutely.
There are a few people who have sent me WhatsApp.
Absolutely, absolutely.
They have sent me a few WhatsApp messages where they haven't been able to join the session. They've been asking me the link, but I was talking, so I didn't look at my phone. Is there any message or link which we can send to them? Please send me a WhatsApp.
Absolutely, absolutely. This particular webinar will always be there on our YouTube
Okay.
channel. I'll share the same with you and then you can forward to the relevant
Okay.
people.
Thank you so much.
Done thing, done thing. Thank you so much, Dr. Girija. Thank you so much,
Thank,
everybody from Team Janitri, and good luck to everybody. Thank
thank
you.
you. Thanks a ton.